This is an interesting case of posterior polar cataract, and where we describe our method of removing the posterior polar cataract. There's been interesting development at the later part of the video, so I would request all of you to see the video to the end, because this actually shows that anything can happen in a posterior polar cataract, even if you've done a perfect surgery in spite of all the efforts. Now here we are showing our oval shaped Capsulorhexis, which I recommend in a posterior polar cataract. The advantage of this rhexis is that, number one, you can slide out a larger disc even through a smaller rhexis, which means you have a longer axis from which you can slide out the nuclear disc, and yet you have a smaller elliptical diameter of the Capsulorhexis on which you can place your three-piece IOL in case of a posterior capsular. So we create multiple rings using my own designed cannula and deliver the nucleus out of the capsular bag. You can see it's a very soft cataract. The nucleus is delivered out of the capsular bag. And after that, since we've created multiple rings doing hydrodelineation with our cannula, we are removing one ring at a time. This is to be done a little carefully and a well-controlled machine with moderate vacuum settings. So you will notice that I peel the layers of the nuclear plate. I do not aspirate them out. I just separate them from the periphery, bring them till the center, till the part of the posterior polar cataract, and leave them. Then I grab another area with the same phaco tip and repeat the same maneuver till I create a centripetal or a flower petal like of a situation where all the petals are attached to the center. Now, before I remove my instrument, it's a must thing that you instills viscoelastic into the capsular bag before you pull out your irrigating instrument. Now, all we need to do is remove the cortical plate using irrigation aspiration probe. You will notice again the same peeling movements layer by layer. Once the layer has been dissected from the posterior capsule, and you will notice that only the small central part of the cortical plate is attached and left on the capsular part. There we flip the irrigation port and we remove the last part of the cortical plate. So the surgery has gone off very well. One thing which I do keep saying in my all videos is that even though the posterior capsule looks very normal, you should not overinflate the anterior chamber with viscoelastic. In my previous videos you've seen I've just tapped on the IOL and there has been a posterior capsular break. Now here I will put in a LuxSmart IOL into the bag, and having learned from my previous experiences, I very softly nudge the IOL into the bag without putting much pressure on the posterior capsule. No tapping on the IOL surface to push visco outside. The only thing is that there's a slight mistake which I make in these cases. I notice some amount of cortical fibers. So at first it seems there are some viscoelastic fibers onto the IOL. I do an irrigation aspiration and I realize that the viscoelastic has been removed. There is some amount of viscoelastic which is in the posterior part, but I decide not to tap the IOL this time. So I inject instead a very slow burst of fluid behind the IOL to wash the cortical fibers and see what has happened. Even the slight amount of pressure of fluid through a 27 gauge, a slow jet of fluid has caused a posterior capsular opening. But luckily for me, there has been no vitreous loss. The IOL already is in the bag. You notice a huge vertical or a linear slit into the posterior capsule. Now I do not overhydrate, neither do I push the IOL backwards. And I'm sure since there has been no vitreous loss, so the IOL will stay in place. This is the tear in the posterior capsule. So again, a lesson learned: in a posterior capsule, it is not over, it is till it is totally over. No maneuvers, no pressure on the posterior capsule, even if the case looks absolutely normal. So there you see a linear opening, but this patient did very well and is maintaining 6 by 6 vision for distance and N by 8 for near. Thank you.